This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Gordon Smith. I'm a neuromuscular neurologist and chair of the Department of Neurology at Virginia Commonwealth University. And today I'm excited to have the opportunity to talk with Laynie Dratch, who is a certified genetic counselor in the Department of Neurology at the University of Pennsylvania. Laynie's primary focus is on frontotemporal dementia spectrum disorders and amyotrophic lateral sclerosis. And she's agreed to join me today on the Neurology podcast to discuss her recent article, which was published in the Green Journal, titled Incorporating Genetic Testing into the Care of Patients with ALS FTD Spectrum Disorders. Laynie, thanks so much for joining us today.
Thank you so much for having me.
Well, first of all, what a great article. Congratulations. I think this is must read. So anyone listening to this, as soon as you're done listening to the podcast, go grab your Green Journal and read this article. It doesn't matter if you're interested in ALS. You did a really good job, and your colleagues, in distilling a complex topic into something that's really digestible. And so thank you for doing that. Let's start with what's exciting about this, at least from my perspective. It's exciting times in therapeutic development in neurodegenerative disease. We just did a neurology podcast with Dr. Suma Babu. And if y'all haven't heard it, I'd check it out. And this was about the approval of tofersen for SOD1-related ALS, right? Super exciting. And so I wonder if we can begin in this moment of energy, and you can tell our listeners, why is this topic so important? And why is this relevant to their daily clinical practice? Why do they need to read the article?
The co-authors that I had authored this paper with and I are part of an ALS and FTD working group full of genetic counselors that now has 60 genetic counselors involved in it, which just, I think, shows you the amount of people that have their heads wrapped around this topic right now, which is really incredible. And I think the energy that has come out of the tofersen approval is palpable in our field. The time sensitivity of not just genetic testing is important, but it's important to offer it early and to everyone is really the sort of sentiment that's being pushed in the field right now. And so I think that the tofersen approval has now made it such that every person with ALS, even if they don't have strong family history, has a little bit of hope in that maybe if this by some chance is genetic, there's something I can do, but simultaneously deals with the fear of if this is genetic, this has implications for my family, which I think is where genetic counselors sit in the middle of that, balancing hope and fear.
Neurology is all driven by history and examination. It's great to have genetic testing, of course, but I wonder if you could talk a little bit about that. This is something you bring up in the article, the importance of family history. And I think many of us think it's not that hard to take a family history, but in reading your article, I was struck. There's a little bit of nuance to this. How do you go about gathering a family history? What advice do you have to our listeners?
This is something that genetic counselors are trained to do, but something that many clinicians have to do as part of their workflow. And so I think it's easy to know that there's certain questions you have to ask if you've got a patient with an ALS FTD spectrum disorder in front of you, which is obviously, is there any family history of anyone else with ALS or FTD, but also related conditions like Parkinson's disease, for example. But I think what's most important is that there are so many reasons why a family history can be missed. And that can be because historically it was harder to diagnose some of these conditions. People might not have made it to the right clinician, or even if they were diagnosed, they might have been uncomfortable sharing this information with their family members, especially on the FTD side. There's some stigma that has been tied to dementia. And so it's important that when you're taking a family history, you're aware of that and you ask questions like, did anybody have drastic changes in their behavior or personality? Did anyone start having social challenges like they lost their job or they became incarcerated or they went through a divorce where it wasn't something you would have expected for them? It was out of character for them to have these changes. And from the ALS side to ask questions like, was anybody in a wheelchair for an unexplained reason? Or did anybody become bedbound? Or was there anyone who had choking issues? Things like this. Because if you ask if there's family history of FTD or ALS, you could be missing clues that families might be aware of stories that have been passed down without formal diagnoses tied to them. And I think it's important to sort of follow the patterns that you observe. So if you're taking a family history and you hear dad got divorced from mom and remarried and then left her and had a whole secret hidden family on the other coast and got in trouble because he was gambling. And then you start asking questions about dad's family members. And if you start to get further back in that side of the family tree and you're hearing more stories, you can follow it even further past the 3 generation and just take down what you know. You never know what might be helpful when you get some variants on the back end that you have to interpret. So I think to be as thorough as you can is really helpful, and understanding that even if there's not a family history, there still could be a genetic form, and counseling people through that as you take the family history.
Well, that's great, Laynie. And I guess I'm just reflecting on that. It's not only important in terms of determining whether or not a patient with ALS or FTD has a familial form. I mean, if you're seeing a patient who might have FTD, getting that history helps you sort out, do they have FTD? So I think this is just a reminder that history is paramount.
If I could add one more thing, it's that when taking a family history, sometimes it's hard to distill what people know down to the information you really need. So it's one thing to ask how old were these individuals when their symptoms started or when they passed, but a lot of times people will say, oh, so-and-so had Alzheimer's, right? Well, we follow up with, was that autopsy confirmed? Was that made by a neurologist? Is that just the term the family used? And did any of these people who had these diagnoses you're talking about undergo genetic testing? Because people might not realize that's relevant to share.
Let's talk a little more about genetic testing. You talk about 2 different types of genetic testing, and I hadn't heard them framed quite this way. That is predictive versus diagnostic. Can you talk to us about that a little bit?
I think this is a really nice way to frame broadly 2 different types of genetic testing and then what resources are needed for them and how we approach counseling them. So diagnostic testing is really the process of genetic testing for a person who's already got a diagnosis, a clinical diagnosis, trying to understand what the cause of that is. So this would be a patient who already has ALS or FTD or some sort of differential diagnosis, looking to get an answer as to why. And then predictive genetic testing is when an otherwise healthy individual, often with a known family history, most often in parent or sibling, is having genetic testing to understand whether they've inherited risk to develop that condition. And so the approach to how we counsel these patients in these types of scenarios is very different.
Well, great. Let's get into it then. So is it okay if I give you a clinical scenario, Laynie?
Mm-hmm.
I thought you might be willing to do that. So let's say I'm in clinic tomorrow and I see a new ALS patient, right? And I do my detailed family history and I'm not getting anything that really sounds like there's a history of ALS. And you make the point in the article that every ALS patient these days really deserves sequencing. So how do you go about it? What do you order, right? There's some complexity to this.
So I'm going to cheat a bit with my answer and point to a paper that recently came out that my colleague Jennifer Rogenbach from Ohio State University led, which is an evidence-based consensus guideline for ALS genetic testing and counseling. It was published in Annals of Clinical and Translational Neurology. And so we can draw a lot for how we would approach a patient in clinic from these guidelines that were published. And even though the focus of that paper was ALS, it has implications for ALS, FTD spectrum disorders broadly, and I encourage everyone to go read that paper. But if a patient comes to clinic, our approach is the Thursday special, where we are offering essentially the same initial workup for genetics for any patient with ALS, regardless of the family history, where we think it's really important to include a panel of genes that we know can cause ALS, which of course includes SOD1 and other relevant genes, but really important to highlight that these panels and the sequencing technology used in them do not often capture repeat expansion disorders. And with ALS, there's 2 really important genes that require separate repeat expansion testing, which are C9orf72, the most common genetic cause of ALS and FTD, and ataxin-2. And so we make sure that those are also included in the workup. And then if that initial workup is non-diagnostic, you can consider broader testing like exome or genome sequencing. And it's also important to keep in mind what else might be on the differential that wouldn't be covered by an ALS panel. So for example, Kennedy's disease or SBMA can have overlap in presentation with ALS, but would require separate repeat expansion testing of the AR gene.
So that's super helpful, right? So not only do we need to be thinking about whatever next generation panel we're using, but need to be particularly attentive to repeat disorders and ALS. This is true in other areas of neurology as well, but really important here because of C9orf. Can I give you another case? This is actually a real one. The case I gave you first was what I might see tomorrow. This is someone I actually saw. And it was actually a really terrible situation, which I won't get fully into, but a lovely woman, wonderful person who came in with a very mild foot drop whose parent had died of SOD1 ALS. And she was petrified. In fact, she didn't want any testing, didn't want an EMG. She was scared to death. This is sort of in the boundaries of diagnostic and predictive testing, but I think it offers you an opportunity to give us some wisdom in what you would do as a genetic counselor, maybe in that patient, and just use it as an opportunity to talk about predictive counseling.
Yeah, so you're sort of describing the gray zone where a person doesn't have a diagnosis, but they've got some suspicious symptoms. And of course, that's going to bring panic to them right away based on what they've witnessed in their family. And so I think the first thing you're pointing out is that there was already a known family history of the SOD1 ALS, right? So whenever possible, this predictive counseling and testing process actually works best if we start with the diagnostic testing in an affected relative. So then at-risk family members can choose, do you want to know your risk status? It's a much more straightforward yes or no answer if we already know the cause of disease in the family. But I also think what you're highlighting here is the importance of getting a genetic counselor involved when we're going to do predictive counseling and testing, because this is what we're trained for. And this is the perhaps scariest type of decision a person can make, right? Do I want to know if I'm going to have this risk for this condition that might have killed my loved one, or I might have witnessed, in my family many times over? And so even if they've got a suspicious symptom, they might still be in denial. It might still feel like a fully predictive test for them. And it's really important for the genetic counselor to get involved from an emotional perspective to help explore with them, why do you want this information? Is now the right time? What are you going to be doing differently with this information? What options would you have in terms of how you could use this information, both medically in terms of trials that might be going on, like the ATLAS trial, for example, for SOD1, but also if there's reproductive decisions you might be making and those sorts of things. Then also the implications for the family. I don't know if this woman who came to you has children of her own yet, has siblings. This information could have implications beyond just her. And I also think to just put a plug in for the importance of counseling about the sort of logistical concerns and legal concerns. Yes, she has foot drop, but she doesn't have a diagnosis of ALS. And if she were to have genetic testing and be found to have the SOD1 variant in the family, that has really important implications for her insurance possibilities. So just quickly, there's a law out there called GINA in the United States that stands for the Genetic Information Non-Discrimination Act. And it provides some protections against discrimination by your health insurance or your employer, with some notable exceptions. But the reason we bring it up is actually really to point out its flaws, which is that it does not protect against discrimination from life insurance, long-term care, or disability insurance. And so, yes, she might have a foot drop documented, but she doesn't have a diagnosis of ALS. So before she has that test in her medical chart, it's really important for her to consider what insurances she has and what she wants someday.
I think almost all neurologists are familiar that we have a pretty big workforce shortage, right? And you point out in the article that's true of genetic counseling as well. And I think a lot of us have a hard time accessing genetic counselors. I think of this a lot like neuropsychology. I did a podcast with a neuropsychologist not too long ago, and we talked about this issue. And so I guess maybe two questions in this. One is, tell us a bit about the workforce issues in genetic counseling, and then what advice do you have for colleagues who don't have ready access to a genetic counselor? Like if I had ready access, you'd be seeing all of these patients. But if I do not, what's your advice? Read the article is the first piece of advice, but what else?
In terms of the shortage of genetic counselors, this is not new. This is something our field has been facing and has been, trying to address for a while. There's only about 6,000 genetic counselors in the United States. And so when you think about this era of genomic medicine and precision medicine we're entering, not just in the ALS world, but in all of these conditions, it's frightening to think about the demand for genetics expertise and the sort of lack of supply that we have here. So we've been really trying as a field to think about alternative service delivery models, supplemental education, how we can work with other healthcare providers to really, the sort of slogan we've been using is practice at the top of our scope. When do you need us most? How can we triage care? And so I think the article was attempting to lay out, how to triage care in this ALS FTD space as we enter this era of really it being important to offer genetic counseling and testing to all persons in this ALS FTD spectrum disorder world. And so I think that we feel pretty strongly that anybody undergoing predictive testing should meet with a genetic counselor. So I think that's one of the easy ones to answer, just because there's so many emotional, practical, legal, ethical considerations that go into that. And then in terms of when else might a genetic counselor be helpful? Yeah, ideally, it would be awesome if we could see every patient with ALS or FTD, but that's just not feasible. So I think if there are people who have atypical symptoms or a complex family history or sort of wonky family dynamics that you're having a hard time navigating, and you could use dedicated time to have someone explore that further with the family, that's when we can really play a good role, because genetic counseling is about so much more than testing, right? We get to know the patient unit is the family. And so we can help explore if the patient doesn't want to test, but the kids are trying to force them to test, or the siblings really want to know, we can help unpack that. Or if someone's really on the fence about whether they want to test or not, or they just need more time to think it through. Also, if you've got trouble with trying to pick the most appropriate test in a situation. So if the differential is like ALS versus myotonic versus SBMA, we can help you navigate the best testing strategies. And on the back end, genetic counselors can be good to loop in if you get a weird result, right? Whether that's an uncertain finding, or if you've got a positive result that of course has implications not just for the patient, but for the whole family. That's really where we can add the most value. And I would say, even though we're talking about ALS and FTD in this paper, this is really true for many neurogenetics indications, right? So anyone diagnosed with these conditions, we can help with the process for testing, but we can do so much more with the counseling as well.
So Laynie, if I might go to another kind of tricky situation that we all face, and that is variant calling, right? Anytime we order a next generation panel, or certainly if you're doing whole exome, you end up with at least a couple of variants of undetermined significance, and different companies report these out differently. Do you have words of wisdom to our listeners when they order a genetic test? How do they sort out variant calling tools that they might use, for instance?
Variants of uncertain significance, or VUSs, are always going to be tricky, and they're not going away. So we have to learn how to approach them. And there's some VUSs that you can glance at and decide this one really isn't that relevant. So for example, if you've got a single VUS in a gene that's associated with autosomal recessive disease, that's very unlikely to be the culprit. Sometimes if you're really suspicious of it, you might be concerned about a missed variant on the other allele, but most of the time, that's not something to really worry about. I would say there are some genes where most of the variants in those genes are not benign. So for example, SOD1, which has come up in the context of tofersen. If you get a VUS in SOD1, pay attention to that one, because most of the variants in that gene are not benign, and there's an approved drug. But where can you go if you're not living in this space all the time? If you don't have a genetic counselor on your team, there's actually genetic counselors embedded in the laboratories that you order this testing from. And so it can be nice to reach back out to the laboratory and ask for further information about a variant that you might not understand or you might be suspicious of. If there's one that you are suspicious of, and there's other living relatives with ALS, FTD, or whatever the condition of concern is, you can try to coordinate what we call segregation testing, where you can see if the genetic difference tracks in the family with the disease. That can be really hard to do with adult onset conditions that are progressive, because people have often passed away. But I would say the take-home message, if I have one, is when you see a VUS, don't rule it out right away, because as the technology gets better and we learn more and more people have testing, sometimes they do get upgraded. But also, don't assume it's immediately the cause, because there are many uncertain findings that end up being reclassified as benign as we learn more.
Can you talk a little bit about how you handle counseling someone who is a minority or from an ethnic group that isn't well represented in the existing databases?
Yes, I think this gets at the heart of the problem of equity in genomics, where this is going to continue to be a problem. And I'm glad that you're bringing it up, because it's something we all need to be aware of and continue to address. But whenever we take a family history or we sit down with a person, regardless of what their ethnicity or racial background is, one of the key things we have to do is provide a risk assessment based on the current literature and what we see in your family history. What's the likelihood that we can identify a genetic cause? And that is harder to do in a person that is not white. And that is because so much of the research to date has been in white European people. And so what this means is that there could be genetic differences that are more frequent in non-white populations that we haven't even discovered as being associated with ALS and FTD yet. And what it also means is that when we get variants in genes that might be more commonly affected in these other diverse populations, they're more likely to sometimes be labeled as uncertain. There might be less we can do to try to clarify the meaning of that variant, which has implications both for the person in front of you and for their entire family, because again, the family is the unit of care here. There's a great paper by my colleague Mason Mesaros that was exploring ALS genetics in diverse populations. So if you Google those things, it should come up. Truly, it is important that we continue to address this problem by recruiting people of diverse backgrounds into research, but also making sure we're equitably offering this genetic service clinically to people of all backgrounds, because the more people that get tested, the more we'll learn and hopefully be able to provide better care in the future. It's also tricky in terms of where funding is being funneled for clinical trials, and C9orf72 is the most common genetic cause of ALS and FTD, particularly in people of European descent. And so while it's super exciting that efforts are going towards developing trials in those spaces, it's important for us to stop and think, well, what about the genes and gene variants that might be more common in non-white populations? Who's going to run those trials?
Well, that's a great answer to end with in so many ways, right? This is an important topic across everything we do. And I think we're used to thinking about disparities in care and access to expensive therapeutics, or even access to see a neurologist if you live in the wrong zip code, for instance, which should never determine your health. But the idea that these sort of disparities are really important from a data perspective is something that many of us don't think about. I've never really thought about genetic counseling as a therapeutic entity. Maybe you haven't either, but it occurs to me that you're counseling people in a therapeutic way when you're guiding them about VOSs, right? And so your ability to either predict something that's ominous, the SOD1 mutation, for example, but probably even equally importantly, maybe not because there's the therapeutic impact there, reassure people that's powerful, because people are pretty panicked about these things sometimes. And the fact that we don't have data to allow you to exert that therapeutic benefit is a real call to arms. So, Laynie, thank you so much. What a great conversation. I wish we could keep talking. Definitely would suggest everyone check out the article. It's not only really informative, it's not very long, and it's easy to understand. So it's a great read.
Thank you so much for, giving time and attention to this topic. Obviously, it's close to my heart. And I would also really just like to thank all of the co-authors on this article who put so much time and effort into making sure that it was understandable and hit all the key points. So thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.